Okay, I think it's time to get started. So my name is Anna Greka. I am an institute member here at the Broad. I'm a doctor at Brigham and Women's Hospital, and I'm an associate professor at Harvard Medical School, and it's my great pleasure to welcome you all here today to the Broad to celebrate with us our annual event focus on rare disease. This year's theme is Decoding Genomes, Unlocking Therapies. And it's marking what is actually nationally the 10-year anniversary of Rare Disease Day today. It is actually the 4th year anniversary of the Broad celebrating this day with an event that raises awareness about rare diseases. As you probably well know, there's about 25 to 30 million Americans who live with a rare disease, one of about 7,000 rare diseases. Many of which are genetic in their cause, and we will be hearing a lot more about that today. So what could be more appropriate than having this discussion at one of the world's premier genetics, genomics institutes as the Broad. Of course, we do not only want to decode human genomes, but we also want to unlock therapies for patients all around the world. So it's appropriate that we commemorate this today. I just wanted to very quickly run through, I started doing this, I care a lot about rare diseases in my own work, in the lab, in the patients who I see in the clinic. So I started this about 4 years ago. And just to run through, in the first year, we had an elegant presentation about rare prion disease, actually, from our own scientists here at the Broad, who are also an amazing example of a patient scientist. That was Sonia Valab and her husband, Eric Minikel. They've been in the news in various outlets. It's a very touching story. Sonia has a genetic prion disease, and they're both working together to find a cure. And so that was a very compelling start to our Focus on Rare Disease series. In the second year, we actually featured the Rare Genomes Project, which is spearheaded by Daniel MacArthur and Heidi Rem here at the Broad. And we had our first guest speaker, Phil Riley, who is a partner at Therapeutics Ventures, but he's also an author of a book called Orphan, documenting his experience with rare diseases and developing therapies for rare diseases over the years. In the third year of this event, we actually, last year, celebrated rare kidney diseases, a subject that is close to my heart, and 2 people from my team, Yiming Zhu and Moran Bella, presented their work. And we also had a very exciting announcement of the founding of the first Rare Kidney Disease Foundation. This was by Richard Nelson, who is now the founder and chair of that foundation and is doing a lot of the awareness work that many such foundations do for representing different diseases. And that brings us to today. So we have a very exciting program today. I would say the best yet today. And so the one thing that I wanted to say, since 4 years ago, we've always had the Beyond the Diagnosis exhibit here at the Broad. Some of you may have noticed it. It's in the Ames lobby. This is a connection I made with Patricia Weltin a long time ago. She's the president of Beyond the Diagnosis and the mother of 2 children with rare diseases, and someone who really came up with a brilliant idea that art can be used as a way to raise awareness for rare disease. And this has completely taken off, and it's become sort of an international phenomenon. So some of the beautiful portraits of kids with rare diseases are featured every year at the Broad and around the world. I understand Patricia is today at the NIH participating in a very similar event. But we have Suzanne Scott this year representing Beyond the Diagnosis, and she will tell us a little bit about her own work and involvement with this wonderful organization. And then we're in for a couple of excellent treats. The first is hearing from Tim Yu, who is a physician at Boston Children's, also a fellow Brody, and Julia Vitarello, Mila's mom. They're going to talk to us about Mila and their amazing journey going from diagnosis to actually a tailor-made therapy within 1 year's time. So it's a truly remarkable story, and I can't wait to hear more about that. And then we're going to hear an amazing, remarkable story in its own right from Matt Might. He is what I would call a father scientist, a computer scientist, who is now the director of the Hugh Cowell Precision Medicine Institute at the University of Alabama. He's Bertrand's dad, and he will tell us about Bertrand's story and how that inspired him to basically start a national quest to discover precision medicines for all kids or all people with rare diseases. So we're in for a remarkable afternoon. I want to again welcome you all. We will end with a Q&A, and I hope that many of you will participate in that. And of course, we have an audience online during this live streaming of the event. So I'm sure that there will be a lot of interesting discussions to be had. So welcome again, and I would like to introduce Suzanne Scott first.
Hi, everyone. My name is Suzanne Scott. I am an artist, a visual artist. I'm here on behalf of Beyond the Diagnosis. As Anna already said, the Broad Institute is hosting our exhibit in the Stanley Building lobby, I believe. Ames lobby, I think is what Anna said. Beyond the Diagnosis, their mission is to raise advocacy and awareness through art. Let me see here. Since Patricia Welton began Beyond the Diagnosis a few years ago, it has grown enormously. It's on an international level, traveling to research facilities, pharma, hospitals all over the world. The idea is that artists donate their time and talent to portray children with rare diseases. There are over 7,000 rare diseases, as I'm sure all of you know. Beyond the Diagnosis' goal is to put a face to all 7,000 of those orphan diseases. Personally, I came to work with Beyond the Diagnosis first as a donating artist. It's become a real passion project of mine, and therefore I ultimately became vice president of the board. Very proud to say that. I was the first abstract artist that Beyond the Diagnosis ever took on. They took a chance on me, and hopefully I'm not the last abstract artist. To describe that, my work is I try to merge science and art. It's based on the human fingerprint. So very literally, I fingerprint my friends and family, old school, just like they were being booked for a crime. And then I blow it up. I scan it. I blow it up to about 8 by 10 in order to read the information, the lines and the whorls. I then take a lot of artistic license to create a portrait that is abstract, emotional, and hopefully describes the individual. This is an example of one of my paintings. This is my brother-in-law. This is his fingerprint, his personality. He is a dentist and also a naturalist, so his happy place is outdoors, fly fishing, hiking, visiting his farm in upstate New York. I hope to illustrate these traits with the choice of color and line. The fingerprint really lends itself perfectly to storytelling because you can put a lot of information in each of these little nuances. What also makes it interesting for me is that the fingerprint itself, obviously formed in the womb, does not change unless exposed to extreme circumstances, but life is always changing. Each person's life story changes and develops, so then I can go on to paint a second or third portrait as their life circumstances change, but the fingerprint does not. This interesting part of my brother-in-law's fingerprint here, this little cross part, I found out it's a scar, and he got bit by a flying bat. I always thought it was because he was Catholic, but that wasn't the case. This next slide is a self-portrait of mine. I've painted my fingerprint endlessly through the years. As an artist, it's the most accessible subject, yourself. Each time I paint myself, it represents a different period in my life, a different phase. My first marriage, my first divorce, my second marriage, my second divorce, as life goes. But it's truly, the fingerprint lends itself for endless inspiration for me. Each new fingerprint is a new story to tell. Each new person I meet is a new fingerprint. This next slide is a photograph of me in my studio, obviously, but the painting shows scale. They can be quite large, the paintings down to about 12 inches square, so kind of intimate. This is a fingerprint portrait of my great aunt. I found her fingerprint posthumously on the back of her Coast Guard ID. She was sort of a role model of mine. She was a pioneer of sorts in her day. She was never married, no children, independent, took care of herself. She worked as a stewardess on one of the first airlines, commercial airlines, when you had to be a registered nurse and also of a certain height requirement. She was a little shorter. Then in the 50s and 60s, she went on to take those RN skills to work on international cruise ships. So she had a lot of great stories to share. In this particular painting, it's one of the few where I actually worked back in and drew phrases and dates, and it's a bit more literal. She had a lot of really incredible stories to share. I hope to tell each person's story with a color and a line that speaks to the viewer on a really emotional level, and they can kind of hopefully take away a piece of what I'm trying to share. I want to take a quick second to just explain why Beyond the Diagnosis really resonated with me on a personal level. My father was crippled from before I was born. All of his joints were gnarled and disfigured. He walked with 2 canes when he was able to walk. He never complained. This is not his fingerprint, but I will explain why. My dad lived in pain every day. He was left with full onset rheumatoid arthritis in his 20s from an allergic reaction to house paint when my mom was pregnant with my sister, my older sister, and it left him struggling for the rest of his life to the point where he needed assistance to put on his socks, to put in a contact lens. These are all lessons that I grew up with, taught me strength and compassion, and I have a better understanding of what these rare kids and their families live with. Interestingly, my father went on to have a successful career as a biomedical engineer for Pfizer, designing implants for people just like him. I was in the midst of painting my dad's fingerprint when he passed away unexpectedly recently, and that remains unfinished, but I will eventually pick it up. This fingerprint is of another huge influence in my life as an artist. Fate had me meet Chuck Close. He is, I'm not sure if you all know, but he is a very world-renowned artist. This is his portrait, and he is a quadriplegic. He suffered a spinal artery collapse when he was 48 years old. He's now 78 years old, and he has never missed a day of painting. He paints with a brace strapped to his arm. He can't manipulate his fingers, but he can lift his one arm to paint canvases. This is a picture of he and I and a portrait he painted of me. I'm fortunate that for the past 20 years, Chuck has been my mentor, my best friend, and now my employer. Between Chuck and my dad, I have learned a lot of lessons, and I see all of these qualities, as I said, in the rare families and children. Chuck sees his difficulties and challenges as interesting problems to solve. He's an eternal optimist, and I see so much of those strengths in these families and children. Which leads me to how I was paired with the subject of my portrait for Beyond the Diagnosis, Julian. Patty Welton curates each artist with each disease, with each child, with each family. This creates a level of compassion, I feel, which is palpable in each portrait that you will see. Julian here looks like a perfectly healthy little boy, but he and his family struggle every day with completing simple tasks that you and I may take for granted. Julian has Leschnian syndrome, an enzyme disease that leaves him with little to no motor function. He has difficulty walking, eating, speaking, frustrating life for him and his family. I spent a few months talking to Julian's mom, Danielle, learning about their daily life, Julian's struggles and triumphs. It's very important for me to gather all of these personality traits and information about their life in order to make a successful portrait that really means something. So his favorite color, his favorite sports team, which is the Patriots. I put all of my findings into his portrait, hoping to depict his strong spirit and character properly to do him justice. When Julian's mom saw the portrait for the first time, she burst into tears. This is Julian's portrait. Art had done its job successfully for me. I believe that each artist that participates with a rare family is touched deeply and will forever remain in each other's lives and hearts. We have seen this over and over through the years since Patty started this. We all become one big family, and the support system for the rare community grows. Art is nutrition for the soul. Art can amplify compassion and sensitivity by sharing deep feelings. Art can portray human struggle, but can also uplift and heal the soul. Art encourages and nurtures what is best in us, gives people joy and hope. If we cannot envision a better world, then we cannot create one. I hope everyone has a chance to walk through the exhibit, meet the faces that are beyond the diagnosis. Each one has its own story to tell. So I hope you enjoy it, and thank you for listening.
How about now? Okay. So once again, thank you all for coming and attending and helping mark this day. It's my privilege to speak to you all today about a story that involves many people, but has taken me up in the last 2 years to meet Julia and her family, her daughter, and the rest of her family. And we're going to try something a little bit different today. We're actually going to try and tell you the story in dialogue. We'll be flipping back and forth between our clinical and scientific presentation and asking Julia to reflect on the journey from her perspective for her daughter, for her family, and what this process has meant. And without saying much more, I'd love to just dive right into it. Okay. So, sitting here at the Broad, it's our pleasure to have been the benefit of an amazing explosion in technology that has made the diagnosis of patients much of a more approachable problem than it was 10 years ago. The machines working 24/7 here, the research being done here to care and feed for those machines, to analyze the data that comes out, all of this has greatly accelerated our ability to diagnose rare conditions and the patients who are afflicted by them. However, the challenge that remains is that developing treatments for these conditions still takes time. To explain, though, how the future has the potential to change, and this gap we have the opportunity to narrow this gap. I'm going to be telling you a little bit about a young girl named Mila, Julia's daughter. Mila is a 6-year-old girl who presented to us 2 years ago with vision loss and neurologic regression. And I'll tell you the story from my perspective, and of course, you'll get the chance to hear from Julia in much more richer detail. But let me first get through the medical facts. So Mila was a typically developing child, precocious by many accounts, until around age 4, when she began suffering a mysterious decline. At that time, her family told us that she was beginning to show some unusual symptoms, including pulling books up close to her face at bedtime reading time, having trouble discerning the letters in low light. At age 5, she began having stumbling and unusual motor movements of her feet, and her family began taking her to multiple specialists. And unfortunately, they were unable to come to a clear answer for her. At age 6, unfortunately, things became much more serious in a very short period of time, and we'll hear more about that. But she began having worsening gait. Her stumbling turned into falling, and she began to bump into things as well. Her speech became slurred. She was using fewer and fewer words, and her behavior regressed. Most dramatically, her vision was precipitously failing. And what had been originally difficulty navigating in low light became so severe that one day I think mom and dad were watching her watch her favorite television show, or her favorite movie on TV. And she was smiling and laughing along with the songs and the music and the lyrics. But her father slipped behind her and dropped the newspaper in front of her eyes, and she didn't flinch. And that was the point when they realized that she seemed to have lost all vision entirely. Now, this, as you can imagine, led to an emergency workup at Children's Hospital Colorado. And she was seen by a team of neurologists, ophthalmologists, and geneticists that after 2 weeks of intense hospital workup gave you a diagnosis. And the clinching finding was an abnormal skin biopsy, which showed these unusual fingerprint-like inclusions on electron microscopy in her skin cells. And that pattern, actually fittingly a fingerprint pattern on electron microscopy, was diagnostic and pathognomonic for a condition called neuronal ceroid lipofuscinosis, also known as Batten disease. Now, Batten is caused, as you learned, by 14 different genes. There are it's a recessive disease, and recessive mutations in these genes, all of which have something to do with the lysosome, cause, unfortunately, a bad cellular picture of progressive neuronal cell death. And the particular subtype of Batten disease that she was diagnosed with was CLN7 Batten disease. And this is a rare subtype of a rare disease, so it's really ultra rare. Only 70 cases reported in the literature. And the clinical picture for CLN7 Batten disease matched what was happening with Mila. The age of onset, typically around age 3.5, the development of vision loss, motor and cognitive decline, eventually seizures. And unfortunately, as you learned, the prognosis was not looking very good. Often, the mean age of death for these children is around age 11. I'm going to pause right there and give Julia a chance to share a little bit from her perspective.
So up until 2 years ago, I had never heard of rare disease. I had no idea that neurodegenerative diseases existed in children. I had no idea that a child that developed normally could lose abilities. Obviously, all of that changed 2 years ago. But before we talk about Mila's story relative to disease, I thought I would just paint a little bit of a picture of what Mila was like as a child before that. She could have really been anyone's child. I think it's one of the reasons why Mila's story has gotten quite a lot of attention around the world. People felt like it could have been their child, and they lucked out in the genetic lottery. Mila was extremely advanced in many ways. She was very, very verbal, speaking long sentences when she was 1.5 years old. We live in Colorado, and she was quite a Colorado kid. She was hiking and skiing when she was 2 years old. She would climb rock walls with all her rock climbing gear on when she was probably 2.5 up to about 50 feet high. She was very coordinated. She was the center of attention, very, very social. So as you can imagine, it was quite a shock to have a child who had all of these abilities lose them. One story I'll just tell you that just always makes me laugh is when Mila was 2 years old, her preschool teacher called us in and said, we asked everyone what they did for Thanksgiving, and this is a room full of 2-year-olds, and they made little gurgles, and a few people, maybe, a few kids said like a word or two. Mila jumped up in the middle and said, they said, Mila, what did you do for Thanksgiving? And she said, I went hiking in Moab and ate baba ganoush. She was a little firecracker and just incredibly, like I said, incredibly verbal. Another time, she went on hikes for, since the age of 1.5, she had little hiking boots. She went on hikes for 2-3 hours at a time, sometimes in the snow, happily. And a group of people came up to her and they said, hey, little guy, aren't you cute? And she said, I'm not a guy and I'm not cute, I'm dangerous. She was 2.5 then. She always kind of caught everyone off guard because she was so little, but she was speaking so well. And then as Tim mentioned, it was very subtle in the beginning. I thought I was a little bit crazy because she was so advanced that her feet started turning inward. And I wasn't really that concerned probably until about 4.5. 4.5 years old, she started acting a little bit differently, and people started using different words to describe her that I had never heard anyone use, like clumsy. I remember my mom saying, oh, she's just a clumsy kid like I was when I was little. And I thought, this is not a clumsy kid. She's incredibly coordinated. Other people, her teacher said, oh, Mila, she just likes to pull the books in close and be kind of quiet and calm herself down. And I thought, she's usually the one that's screaming and running around in the room and the center of attention. So clearly something was changing in her character. And I was very worried, but no one else around me was worried because it was subtle and she was still advancing. By the time she was 5, I was very concerned. I brought her to, I don't even know how many, probably 100 doctor's appointments around the country. Many neurologists, orthopedic doctors for her legs and feet that were turning in, many ophthalmologists, of which the top one in my area told me that his advice to me was to chill out and just relax, that all of her tests were fine. She was identifying everything. That was 6 months before she lost her vision completely. So this was unknown. I had no idea that there was a possible genetic cause underneath this. I was told that she was delayed, but delayed didn't make sense to me because she had advanced so much in her first 4 or 5 years of life. At some point I gave up and I just put Mila in the car and brought her to the emergency room, and I figured there's no way they can release her. There's just no way. And in fact, I was right, and they kept her for over a week, as Tim mentioned, and did an incredible amount of tests that ended up in diagnosis of Batten disease. I very quickly, I would say my first reaction was that I felt relief, because for 2 years leading up to that, I thought I was crazy. And I thought, how is it possible that she's losing these abilities and I'm the only one seeing this? And then I learned what Batten disease was. And I learned very quickly that there was no cure, no treatment, and that it was 100% fatal. So I read everything I could possibly read about Batten disease, about lysosomal storage. Every time a scientist's name came up, I reached out to them. I bothered them until I talked to them. And I asked the same question over and over again: is there any reason for me to fight? And the first reaction I got was, I'm so sorry. Batten disease is one of the most horrible diseases I've ever come across, often as a neurologist or scientist. And enough people said to me, if you had called me, this was in December of 2016, they'd said, if you had called me a year ago, I would have told you to give up. I still think we're 5 to 10 years away from stopping this disease, probably more like 10. But there is some little reason to believe that we might be able to stop genetic diseases like this soon. That's all I needed to hear. I spoke with other parents of other foundations. A lot of them, if not all of them, had lost their children because it was too early for there to be any hope for treatments for their children. I followed in their footsteps. I started a foundation. I didn't even know what a foundation was. I didn't know what a 501c3 was. I started it, and I just started telling Mila's story. I told it to anyone and everyone. I had news and media in my house all the time. I can tell you it was the last thing in the world that I wanted. I was crying on the floor of my closet with the door shut so my kids couldn't hear me every day. And I would get up and wash my face and put on some makeup and go downstairs with the news crew that would come in. And I realized early on that if I wasn't open about what was happening, I was never going to be able to make a change. And so I wrote a blog. I became very active in social media, which I was not before that. And I just told Mila's story. I learned quickly that gene therapy was going to be her only shot. People didn't and still don't really understand Batten disease and the mechanisms behind it. So gene therapy was our best shot. It was also about $4 million, now even more, but at the time, $4 million. Extremely daunting task. So I made a video, luckily had friends step up in every way possible, and one of them were people that worked at, two of them were people that worked at an advertising company. They just showed up at my house within a week of Mila being diagnosed. I did not want them there, and they made a film that was 5 minutes, which I will show you now, and it really allowed me to tell Mila's story, or allowed people to really see Mila and really see how she was and what was happening. And it really affected a lot of people around the world. And eventually, through very grassroots efforts, I raised about $3 million from probably about 6,000 people in about 55 countries. Many of them sent personal messages, moms, dads, aunts, uncles, kids, a lot of kids, saying, we want to help, and we've told our school, and we've told our church, and we've told our synagogue, we've told our community, and they're all stepping up to help. So thank goodness I made this video, and I just want to share it with you because it really explained what was going on with Mila.
So our daughter's name is Mila Virginia Makovitz. She was born on November 5th, 2010. When I think about Mila as an infant, I think about smiles and laughter and health and...
Half an hour after she was born, she was strong enough to hold on to my finger, and I could almost pick her up off the bed.
When Mila was a toddler, she was a climber, she was a hiker, she was a runner.
How old are you, Mila? Here's our sugar high daughter.
Slide, slide, slide. Woohoo!
Very physical, always loved to ride a strider.
Nice, bug.
Play in the snow, go sledding.
Coming!
We noticed that Mila was getting stuck on her words. She would say, "Mommy, Mommy, I have to, Mommy, I have to," and not be able to continue. And then suddenly, around 3 years old, we started noticing that her feet were slightly unturned and she was walking strangely. And then at 4 years old, we noticed that she pulled books in close. And then around 5 years old, Mila's feet started moving really quickly in this strange pit-pattering way, and then she would fall back on her butt. And every time she stood up, she would fall back and stand up and fall back. You know, we took her around to different doctors who never could really kind of figure out what was going on with her. And then time passes, and then in just 1 month, everything can change. She could no longer see anything. What's brought her so much happiness is playing with her toys and or looking at her books and watching TV and playing with her brother, and suddenly it looked like she could no longer play with anything. It's so hard to see such an outgoing little girl not be able to play with other kids and not be able to play with toys and not be able to watch Elmo anymore. Children with Batten disease are destined to lose their vision, their ability to walk, their ability to talk. They lose their ability to swallow, and they eventually become bedridden, and they don't usually live until much after 10, 11, 12 years old.
It's such a rare disease that all the doctors that you see have never experienced it before.
When Mila was born, it was the happiest day of my life. It gave my life purpose, and I just asked myself all the time, how is it possible that we have such a wonderful life? And then we had our son.
Aslan, he's 2.5, but you know, he doesn't show any sign of being affected, but we know that there is a chance that he is.
The night before we took Mila into the hospital, he looked at me at the dinner table and said, "Mommy, is Mila going to be okay?" Our beautiful family and life seems like it's slipping away every day. Her smile and her laughter and her spirit is the same. If we want to save Mila's life and the life of other children who are suffering from this horrible disease, we need to raise $4 million right now to get a clinical trial up and running. We want to do everything that we can to stop other families from experiencing the pain that we're going through right now.
You never know, do you, how much I love you. Please, please don't take my sunshine away.
Oh.
I love you, Daddy.
Blow him a kiss. And tell him one more time. Say, I love you, Daddy.
I love you, Daddy.
Autoplay. Sorry, Julia. Oh, actually, we have to start the one more time. We'll get this right. So, as you can see, Julia and Mila's family. How's that now? As you can see, Julia and Mila's family really rallied remarkably, and they did what a lot of families do now. When confronted with a terrible condition like this, they decided that they were going to take matters into their own hands and really start advocating for their families and for their new disease community. Now, there was a clinical and scientific wrinkle, however, to her case, and that was the following. So the trouble actually that they quickly ran into was that Mila's family had only been given half of a diagnosis. As we've mentioned, there are 14 different genes that cause Batten disease. Each one of them works via a recessive mode of inheritance. And even though we had a secure clinical pathologic diagnosis of CLN7 Batten, molecularly, the team was only able to find half of the diagnosis, one single mutation. This single mutation was a known pathogenic mutation that had been described in Batten before, so that your physicians could tell you with confidence that this is likely contributing. However, the second mutation was nowhere to be found. Dr. Larson, your geneticist in Colorado, appropriately told you that it was probably okay, that this is likely CLN7 Batten disease. But there was a residual worry that all of these efforts that you were putting into starting a gene therapy, is it actually the right diagnosis for her child? And strictly speaking, it would be nice to have 2 molecular alleles confirmed as one of the entry points into such a trial. And so there was even the question of whether or not, if you raised the money, whether an investigator would have been comfortable proceeding, not knowing for sure that that was it. So Dr. Larson appropriately recommended that she needed to have whole genome sequencing. The question was, this is late 2016, early 2017. There's not yet a whole lot of clinical outlets offering whole genome sequencing. That remains true. So where would this happen? So it was because of this situation that on January 13th, I turned to my wife on a Friday night, and she said, hey, I've got something to show you. She showed me this post that had showed up in the Physician Moms group of Massachusetts. This is a Facebook group where physicians and scientists get together and they share professional networking advice, referrals, sometimes work-life balance. And an old college friend of Julie's had posted this message on that site. Actually, I think that person is here in the audience. So thank you for bringing the message to us, Jessica. And it said, I'm hoping the power of PMG can help my dear friend Julia. Her 6-year-old daughter has just been diagnosed with Batten disease. Their doctors are recommending whole genome sequencing. If anyone can help in any way, Mila's family would appreciate it so very, very much. And seeing that, we decided that we wanted to do something. And so that weekend, we called up Mila's family, and we said, look, this is something that we have some expertise in. We've been doing whole genome sequencing for 10 years, and let's try and help find an answer for your family. 4 days later, we had consented the family to our research protocol at Boston Children's. About 7 days after that, we had blood samples shipped to us, and about a month later, we had done whole genome sequencing of Mom, Dad, Mila, and her brother, Aslan. And this is what we saw. So here is the genome sequencing from Mila and her mother and her father. And what we're looking at is just zoomed in tight on the region of the CLN7 gene. And we quickly were able to find the known clinical pathogenic mutation that it turned out was inherited from her father. This is a point mutation, a known pathogenic mutation, was already known. And that allowed us to narrow our search for a second mutation that was presumably inherited from mother. And we then next noticed that there was something unusual that fit the pattern we were looking for. There was a cluster of unusual reads in the 6th intron of CLN7. And here they are circled in yellow. They were present as these really small colored reads that's hard. When we zoom in close, we can get a better look. But on closer inspection, we were able to see that what these reads represented were actually chimeric reads. These were reads in which intronic sequence from CLN7 was fused to a foreign DNA sequence, not present in the reference genome. On one side, it was fused to tandem GGG-AGA repeats. On the other side, it was fused to a different sequence, a poly-T sequence. And the details of this aren't critical unless you happen to be an expert in retrotransposon biology and recognize that actually that kind of signature fits exactly a mobile DNA element in the SVA retrotransposon family. These are jumping genes that are present in about 3,000 copies in our genome, and they start on one side with a poly-A, well, they start with a CCC-TCT repeat, and then on the other side, they end with a poly-A repeat. And so we were seeing the ends of this sequence captured on our chimeric reads. And this allowed us to deduce that an insertion event had occurred in her CLN7 locus outside of the region of capture of a typical clinical exome or panel, and that this was a very suspicious and likely candidate mutation in this case. Okay. What was the effect of this? Well, actually, to have an impact, this has to have, obviously, a molecular biological function. And we hypothesized and then quickly confirmed that this was actually creating a poisoned exon in the gene. This insertion of an SVA retrotransposon was causing activation of a splice site and trapping the gene such that you couldn't make normal gene product from it. The new exon that was generated had a stop codon immediately upon splicing into it. And so you ended up with a truncated and then degraded RNA product and no protein. Right. So this was, after several months of work, a satisfying answer for us. We had done what we set out to do. We had found the cause for her missing second mutation, and this allowed us to tell you that, in fact, she did have CLN7 Batten disease. Thankfully, as you saw in the video, there was the question of whether her younger brother was affected. And it was a happy day when I was able to call you and tell you that he didn't carry this mutation, and so he was actually therefore clean. Right? And if we stopped there, then perhaps this would be a nice story to share with you about the perils of sequencing in the days of rare disease when we haven't fully captured the whole genome yet. But there's more. And what that more was that we realized pretty quickly that we had an opportunity here, a really unusual opportunity, which was to try to fix this. What was the idea? The idea, which we initially hid from you, but eventually shared with you, is that we might be able to develop an oligonucleotide that could block the usage of this abnormal splice site caused by your daughter's mutation, and use that to try to restore normal gene splicing for her benefit. Now, where does this come from? Well, this is actually an idea that's been around for a long time. 2 or 3 decades of work has gone into the development of oligonucleotides to do this type of thing. But we were really only emboldened to try it because at that time, spring of 2017, we were reading about the amazing successes of a drug called nusinersen. And nusinersen is a splice-modulating antisense oligonucleotide, a short synthetic piece of DNA, that we were reading about how injections of this drug into the spinal cords of patients with spinal muscular atrophy were having remarkable effects at reversing the course of the disease. These are young infants. If you don't know SMA, this is a condition where infants are born weak and get progressively weaker, usually typically pass away by age 2. And injection of a splice-modulating drug into the CSF space was able to allow these infants to now actually begin sitting up, and then beginning standing, and then beginning walking, and then really looking much more like a normal neurotypical disease course. And the results were so impressive that we thought, well, gosh, why can't we do that for Mila? So we developed a scheme based on reading all of the papers that we could about the development of nusinersen, in which we would try to alter splicing, the abnormal splicing caused by her mutation, and test this in fibroblasts that we would request from you and the family, and lymphoblasts, and hopefully try to restore normal gene splicing. Now, of course, it took, in nusinersen's case, 10 to 13 years for this drug to come to fruition, but we had the benefit of hindsight. We could go back, review the papers, just see what were the pivotal experiments that they did, and even use the exact same conditions and use the same standards to judge whether or not our drug candidates were working as well, for instance, as nusinersen was in those early preclinical trials. So that's what we set out to do. Initially, again, sort of being coy about it, because we didn't want to distract you from your gene therapy course. But pretty soon, we had some results that were worth reporting to you. We initiated a screen to restore CLN7 splicing, designed a series of oligonucleotides, and were able to quickly find that we could find one that could reverse the ratio of abnormal to normal splicing. Normally, at rest in her cells, in our assays, we were seeing a normal to mutant ratio of approximately 1 to 2. And our initial experiment actually showed one strong candidate that actually flipped that on its head. Now we were getting 3 times as much normal splicing as abnormal. And so that was extremely promising. And with lots of repetitions and increasing our n's and trying it in different cell lines and having independent blinded replicates in another lab, because we didn't want to just, we wanted to make sure that we weren't actually being too biased because we knew all of you. We were able to quickly get to a lead candidate that had properties very similar to nusinersen. It was about 22 nucleotides, just a little bit longer than the existing Spinraza nusinersen drug. And it worked at concentrations that were similar to where nusinersen was. So it was looking as potent as that other drug. And so with that, we were able to do some RNA-seq experiments and convince ourselves that transfection of this reagent, this oligo, was boosting levels of normal splicing from only about 10% in her cells to about 30%, a 3-fold change. And this is about the range of change that was seen in nusinersen that ended up having real significant clinical impact. So we thought that we were doing pretty well. What about function? Well, we took a look at the cellular function, and we looked. We know that these genes are involved in lysosomal function, and we know that in the absence of functional gene product, lysosomes build up, they accumulate. And in the left panel is a wild-type electron microscopy section. In the panel to the right of it, you see the accumulation of these white bubbles that represent storage material and increased lysosomes, the duplication of lysosomes within sick and afflicted cells. And what we found is that oligo treatment reduced the amount of storage accumulation as shown in the samples in a green box. And we looked at a whole series of other measures as well with our good collaborator Joe Mazzulli at Northwestern, who had developed and applied a series of these various lysosomal trafficking enzymes assays, all of which convinced us that by every measure, actually, this drug candidate was working remarkably well. So let me pause and just recap our timeline here. December 2016 was when your family first got the diagnosis. January was when we first spoke. February, we were doing whole genome sequencing. In March, we found the retrotransposon that was the answer for the missing mutation. In April, we began to delicately talk to you about the fact that we were going to work on this project to see if we could develop a therapy. But we said, don't stop your gene therapy work, because that's the most likely and most proven path. In May, we were generating patient cell lines. In June, we were designing oligonucleotides. In July, we began talking to the FDA, because we didn't want to really do this and continue extending hope without some assurances that there would be an appropriate final path to getting this into a patient. So we began to negotiate with them and collaborate with them to find out what would be necessary to meet the bar of safety to administer this. And August, September, October, we actually were beginning to get really pretty good results. So how are you guys doing during this time?
So just backing up a little bit, when I first started my quest to look for the missing mutation, most clinicians and scientists, not all of them, but most of them said that it was a waste of time. It was very obvious that Mila had Batten disease, and she had one known mutation in this MFSD8 gene, or CLN7 variant, and it didn't really make sense to be going down this route, and it was very unlikely that any lab would actually spend the time digging, and even if they did find something, it was unlikely that they would be able to understand what it was doing. And I can't tell you how happy I am that I continued pushing. I didn't understand any of this. I'm not a scientist, but I started reading about it. I started reading about different types of sequencing, and I pretty quickly realized that whole genome sequencing was the only hope that we had. I found out that there was, this lab in Harvard that was not Tim's lab, and I put this Facebook post out, which Tim just referred to, and thank goodness my amazing friend from college reposted that. Otherwise, we would have never crossed paths. But I had no idea when I started this quest. It was really first and foremost to be able to test my son. I didn't want to be testing him for one mutation and find out that he had that, and then I'd be left in limbo. He was only 2.5 years old, well before my daughter had symptoms, and every day it was just killing me, and I had to be able to test him. And on top of that, if I was going to be giving Mila the only shot she had at gene therapy and spending, trying to raise $4 million in 1 year, I wanted to make sure that I was going after the right gene. And I really, really pushed through a lot of people telling me that it wasn't necessary. So luckily, we crossed paths, and I had no idea at the time that searching for this missing mutation, which ended up being this retrotransposon, would take me down an entirely new treatment path. In April, just a few months after we had spoken for the first time, as Tim showed you on that timeline, I will never forget the phone call I got from Tim and Mila's geneticist at Colorado Children's Hospital, Dr. Austin Larson. Together, they called and they said, Tim has figured out what the culprit is, and your son doesn't have it. The best moment of my life. And then there was a pause, And then I just remember sitting there thinking, thank God my son doesn't have this. And then he said, our geneticist said, Tim has something he wants to tell you. He has an idea of how he might be able to help you. And I can't tell you it was hard enough for me to even get a lab to even look for this mutation. And then to have someone to step up and proactively say that they had thought about how they could translate that into a treatment was unbelievable to me. It's still unbelievable to me. That he actually thought outside the box and thought about nusinersen, which obviously the timing was pretty incredible, that it was passed through the FDA the week after Mila was diagnosed. And he took it one step farther, and 6 months later, as I was working on the gene therapy, because we didn't know if this was going to happen or not, I was working very hard on that. But 6 months later, I get a call in October saying, it's probably time to get on a plane and bring Mila to Boston to get her checked out and to chat a little bit more. And once we flew there, we sat in a meeting, and Tim showed us some of the slides you just saw of Mila's cells being, returned to kind of a functioning cell, which seemed pretty incredible. We had no idea that we were coming into that meeting to hear this news. And at that moment in time, I'd been working so hard on gene therapy, and I was pretty much alone working now on 2 pretty huge genetic treatments. And I couldn't do them both. And what was supposed to be, this ASO was supposed to be maybe a way of buying time for gene therapy. And now, looking at the fact that this drug that Tim had, this oligo which Tim had designed, was restoring function to Mila's cells, and the gene therapy was going well, but it was far away from becoming a trial and a reality. There was no doubt in my mind that I had to shift focus. I couldn't do them both. I was killing myself. I wasn't sleeping. It was a working day, being a mom during the day and working all night. And I couldn't do them both. So I handed the reins over to another foundation to work on the gene therapy, which we're still very involved in. And I really shifted the focus right then, that day, when we were in that meeting, to saying, this is Mila's shot. And this is, where I need to put my all my eggs in this basket. So I was kind of juggling both of those for 6 months. And, once we came back from Boston in October, it felt like Mila actually had a real shot. I wasn't just saying that, like there was a gene therapy and maybe we could get there. It felt like it might be happening kind of soon. So it was a big deal to come back from that trip.
So it goes without saying that as this work was going on, we had a real sense of urgency to complete it fast. And in fact, we actually asked Julia and her husband to write a letter describing what was happening with Mila during the time when we were working busily in the lab. And unfortunately, from just in the 8 months between January and August, as shown in this letter, there were palpable signs of decline. So we knew that we had to move very, very quickly. And on one hand, as pleased as we were that we had something that looked like it was working, and we knew that there was plenty of work to be done. And proof of concept was really all we had accomplished at this point. And the typical drug development path, as you know, takes years, and there are many, many more steps to be navigated, most of which we knew very, very little about. Physicians and scientists, but this was a whole different ballgame in the pharmaceutical development industry space. And so, but we said that we're going to give it a shot because there weren't other good options at the time. And so we began calling around and talking to various folks about our various options, and we quickly hit on the idea of trying to obtain approval with the FDA's help for administering this to our patient through expanded access. Now, this is a path that many of you in the audience may know very well. It's typically used for repurposing of drugs that are developed for one purpose, but then you want to give it to a patient who is in dire straits for a second purpose. And there really had been no precedent for using this route for an entirely brand new drug. So we had to consider a number of issues. Now, luckily, we were able to find help. Many of the folks who helped us are listed on the slide. Some of them are here in the room, and there are others who aren't on the slide but are on later slides. And we spoke to everyone and anyone in industry or industry or regulatory experience to help us design our path. And they helped us deal with tricky issues like this. So for manufacturing, for instance, just to take one, making the drug quickly and safely is the critical step. Given intrathecally, we have very little immune protection. So issues of contamination with microbials or toxins are paramount. We needed a very small batch. We calculated that to give her a lifetime of supply of drug, we might only need 10 or so grams of material. And this was 50 times less than most of the GMP manufacturers, the good manufacturing practice manufacturers that make drugs for the pharmaceutical industry. It's 50 times smaller than they typically do. We needed it yesterday, whereas oftentimes these contract manufacturers are booking 6 to 12 months out in advance. And it had to be super sterile. And the regulations for manufacturing at this scale and this speed were really not clear to us. Nonetheless, with lots of help, we put together an aggressive timeline. And really, folks emerged out of the woodworks pro bono to offer their advice on this case. And we managed to set a pretty aggressive timeline to get synthesis and formulation done in just a matter of months, to do quality testing to make sure the drug was clean, and then to immediately start testing this in rats in order to obtain some modicum of animal safety data before we actually inject a patient. And this was a pretty aggressive timeline, probably the fastest timeline that anyone has dared try to do. But the circumstances were so unique and we had so much help that we felt that we could take a stab at it. On December 12th that year, we actually managed to finish the manufacturing. And with the help of TriLink Biotechnologies in San Diego, they made 18 grams for us. It was very pure. It matched the appropriate size and mass that we were expecting. The quality release tests all were meeting our specifications. And we moved on to the next issue, which was animal testing. With Charles Rivers' help and the expert guidance of Lauren Black and Julie Duvel and a number of others on the slide, we started intrathecal injections to test to make sure that this drug was sufficiently safe for us to get going in patients. We had three cohorts of rats going simultaneously, one getting a single dose, and those animals were sacrificed after a week. And then other cohorts being taken down at 3 weeks and 3 months. But we weren't going to wait for 3 months. We were going to actually petition the FDA to start treating partway through before all the rat data came in because clinical time was precious. We developed a clinical protocol, and with my colleagues at Boston Children's, we decided to administer this just like nusinersen. And we took advantage of the fact that we've been giving nusinersen at Boston Children's since the early phase 1, phase 2, phase 3 trials. And so we used this protocol, but with slight modifications for our case. We put in a gradual dose escalation procedure so that we wouldn't jump in at our target dose right away, but we would start small and escalate up. And we installed all the necessary safety monitoring that would be necessary for a drug in this class. And with all of that cooking, the family moved to Boston in January 13th, set up camp. We actually hadn't received approval from the FDA quite yet. That came just 6 days later. We received a permission to proceed letter from the team at the FDA that was following our case and working closely with us. And we actually hadn't received the drug yet until 6 days after that. The drug finally cleared all of its final release tests and arrived in 2 precious boxes, filed away carefully into our freezers in the pharmacy. And we successfully got to the point where we were launching our trial January 31st. Julie.
So during all of this time, Mila had been regressing in line with her disease over that year, but not steeply. And then right after her 7th birthday, so at the end of November 2017, she went off a cliff that was very typical of Batten disease. Everything got worse. This was at the exact same time that the drug was being made, or had already been made, possibly around that same time. So it felt like we were almost at the finish line, but just at that exact same time, Mila's symptoms got worse. And she had had absence seizures. You would never have noticed any of them. They were barely noticeable at all, and I don't even know how many there were even in one day. And suddenly they shot up in a very short period of time to 10, 20, 30 gelastic seizures a day where she was laughing. We thought it was kind of cute in the beginning. It got really out of control. And within just a few weeks, I was having to hold her down with all of my body weight at the dinner table while her arms and legs were thrashing. She was smashing her knees up against the table. You know, she was pulling her arms in and out, and they were lasting up to 2 minutes, and she was having up to 30 a day. It was getting worse and worse. Her upper body strength she started slumping. I had just told someone how well she was sitting, and the next day she could barely hold herself up sitting. At some point, I remember holding her and walking her into the bathroom and looking in the mirror and seeing how strong my arms were, and I realized I was holding her entire body weight up. She was really not able to hold up her upper body, and her posture was just going. She had been eating pureed foods, and suddenly she was coughing and choking, and I was extremely worried that she would aspirate. And so I started giving her more and more supplemental food through her G-tube, to the point where I was supplementing most of her food through her G-tube. She was coughing and choking. Everything was getting harder, and I think by far the hardest thing for me was right before we were moving to Boston in mid-January, where I felt like we were just almost there. For the first time, I felt like I was really losing her as a person. And you know, she was so outgoing and so smiley and laughing, had this bright smile, and she was not laughing at the same parts of the books or the songs that I used to read to her or sing to her. And you know, my heart was just dying. At the same time, when she was being given this amazing chance, she was going down so quickly. And I think this is really important to remember when you're thinking about, you know, translating any work in the lab into a treatment. You know, urgency is extremely important in a lot of diseases, especially like Batten disease, because it can seem to be going, you know, downhill in a predictable fashion and then just fall off of a cliff. And so we moved to Boston, and like Tim said, you know, luckily everything happened in an incredibly fast manner. But I have to say, you know, as a parent of a child who was going to lose everything, I wasn't scared. All the risks, the risk-benefit, it was in one ear, out the other, because Mila, you know, what was the risk? The risks were that she could lose her vision, she could lose her ability to walk, to talk, to swallow, you know, and lose her life. I mean, all those things she was gonna lose anyway. So for me, this was an incredible opportunity, and there was nothing scary about it. And then, do you want to go to the next slide? I was writing a blog during this period of time that had nothing to do with raising money or anything else, just really kind of the emotions I was going through during that year. And the night before her treatment, I wrote an entry, and I'll just read a really short excerpt from it. I was sitting, you know, there 12 hours before Mila was going to get injected, and I had no idea what was going to happen, as this had never been done before. And I entitled it "Between Hope's Edge and a Miracle." So just a short excerpt. On the eve of Mila's treatment, I'm filled with many emotions. I've pushed so hard over the past year to get to this point that there was little room left to think or feel. Now I'm here, sitting on the hardwood floor of our rental house in Boston with my back against the wall. Mila's treatment is scheduled for 12 hours from now. I hear myself breathing. I feel my chest expanding and collapsing. I look around the room and seem to notice every detail. Perhaps because this is the first time I've allowed my eyes to drift in over 1 year. Part of me just wants to hit the fast forward button and have Mila's first treatment behind us. But something pulls me back. Deep down, I know that I am in a sweet spot that I may never be in again. A spot between hope's edge and a miracle. Tomorrow, Mila will receive an injection of a new medicine that will go directly to her brain. It is experimental, which means it could be that breakthrough treatment that makes the impossible become possible, or it could be a valiant attempt that just falls short. She could be the pioneer whose life is saved, or the one whose sacrifice helps those that follow.
So we launched our trial on January 31st. And where are we now? It's February 2019, so we're about a year in. And how's she doing? Well, obviously, you're going to get a chance to hear from Julia about that. I'll share that from our standpoint, obviously, getting going, we were concerned about safety. Her schedule of doses is shown up on here. She received doses every 2 weeks for approximately 3 months. And as she went through the dose escalation, we were gratified to see that the doses were well tolerated. There were no adverse events during that period or seen. How about outcomes? Now, this is a tricky case. And frankly, I think in many clinical trial protocols, well, it's a truism that treating as early as possible is always better. But we had several things to follow. We followed neuropsychological measures. We followed neuropsychological measures. Are you okay? We had seizure logs, repeated video EEG measurements, and neuropsych measures. And how did she do? Well, this is what we've seen so far over the last year. With respect to her neuropsychological measures, these are fairly gross instruments. And I think you'll get much more richness directly hearing from the family in that regard. What we see clinically is that things have been roughly flat. We've not seen marked declines in cognitive or language or motor measures over this last year. And that's something, because in Batten disease, you often can see really accelerated decline. Her seizures are shown on the right. And what we have here are lists of frequencies on the left axis, and in the red axis, each dose. And what we've noticed is that her seizure frequency has declined significantly. This is her trend over the first few months. And we were seeing a high of really typically 20 to 30 at the start. And that trended all the way down to in the 0 to 10 range. On top of that, the intensity of the seizures by both parental report and EEG recording seems to have improved significantly too. That bar graph on the bottom shows that the percentage of seizures that are lasting greater than a minute. And it was nearly all of the seizures at the beginning. But by the end, really it's very, very few. Most of them were lasting just a matter of seconds. Now, this is an N of 1 trial. There's no placebo control. There's no crossover. There's no statistics here. I'm speaking in a Broad auditorium. There's no p-value. But is, I think, still instructive to think about what can be learned from cases like this and the opportunities to help patients and also learn about their diseases and also learn about these therapeutic options that we've got. I'm going to, let's see here, pause here and actually give you a chance to share a little bit about what you've seen.
So, can you hear? So, the year leading up to Mila's treatment, between her diagnosis and the treatment, Mila lost so much. She lost her vision. She lost her ability to talk. She lost almost all of her ability to walk. She was almost fully losing her ability to swallow. Obviously, she went into this treatment not in a perfect place, but she was still there. So I was fighting for her because she was still, even though she was just starting to lose sometimes when she left at the correct moment, she was still bright-eyed and smiling and listening and responding, not as much in that last month, but still responding quite a lot. And since then, in the last year, some things have been very obvious, others have been more subtle. I would say that overall I haven't seen any decline. So she was spiraling down in that first year before the treatment. And since then, she's been stable, and we've seen some really important improvements, so seizures being one of the two probably most obvious things. She's never had any of the seizures that I described earlier of hands and arms moving, and kicking the table. Now what they look like is we've had a number of days with 0. Sometimes they range between, 2 and 12. And they usually last a few seconds. If you came in our house, you would never know she had seizures. She laughs and then comes back. That's it. She smiles. So it is drastically improvement of quality of life for our family and for Mila. The thing that people commented on most that hadn't seen Mila in a 6-month period of time from right before treatment, and then we came back to Colorado, was how well she was standing and how well she was sitting. She holds her body up so well. She holds her neck, her head. She can sit unassisted. When I put her against my body, I can go and grab things, and she, is kind of balancing because otherwise she'd fall over, but she's upright and strong. Her swallowing is down to the point where I have not had to give her any supplemental food through her G-tube since probably 2 or 3 months into the treatment. I only give her water through her G-tube because she can't drink thin liquids that well and couldn't before either. So, once again, quality of life. She eats like a champ. She eats so well. I mean, she has pureed food, but she eats all her meals perfectly well. Once in a while coughs, but nothing like before where she was choking on every bite that I gave her. Her rigidity in her arms and her legs was getting kind of typical of a lot of neurological kind of conditions, was getting a lot tighter, her arms and her legs and her hands. And what does that mean? It means as a kid, she can't hold anything or play with anything. And at some point, about 6 months into her treatment, I kept hearing her tap and thinking, I haven't heard tapping in a while. And I realized it's because her hands were so tight. They still close. None of this is perfect every day, is not the same, but they are much looser and they open up by themselves now. And when I go over to the wall, she scratches the wall, or I give her a toy, she opens it up very slowly and feels it. She feels her hair now. They're subtle, but these things are really important for her quality of life and very noticeable to me as a mom. And just most importantly for me is every day is not the same. She's right now has kind of like had back-to-back colds. She's not nearly as responsive as normal, but knock on wood, she has been coming out of that every time, and she is still wide-eyed and listening and alert and laughing, and those songs and stories make her laugh. So, it's been pretty remarkable. It's hard as a parent because obviously we raced faster than the speed of light here to do the impossible and give her this treatment. And now I'm working very hard on trying to try to rehabilitate her, which is another unknown area. There is no precedent for it. But at least her quality of life right now has been stable, improved, and just, I feel such a heavy weight that has just fallen off of my shoulders, and I just feel like Mila's got a shot here. I don't know if it's in time for Mila. It is too early to know that, and she's faced with a lot. But I do know that I'm extremely dedicated, and it's why I'm here today. It's why Tim and I have been speaking about this with anyone and everyone, is I am not going through this, and I'm not having my daughter go through this unless it can have an impact on many, many other families and children living with rare disease. Until you enter that world, my life was completely different, until I turned 40 years old. I lived all over the world and spent, traveled and had all my own personal passions. Those are all kind of like down the toilet. They don't mean anything to me right now. I'm really motivated to inspiring other people to, whatever you guys are working on, think about how you can translate it into a way to help a family like mine and a daughter like mine. There's millions of people out there that need that, and I'm really excited that we're in a day where it looks like there's hope. There is hope. Mila's living evidence of it. So, yeah, just hoping we can keep the ball rolling.
Thank you so much. I think why don't we pause there?
Yeah.
Sound good?
Wow, this is a truly remarkable story, and we're in for another one right now. Matt Knight will take us through his story and his son Bertrand's story. So, Matt Knight.
Mic slips. Can y'all hear me? that better? All right. All right, well, it's a pleasure to be here spending Rare Disease Day with you. Note to self, do not try to follow Tim and Julia. It is a tough act to follow, oh my goodness. Well, what I'd like to do today is really cover three things. What I want to tell you first is what is precision medicine, because I want to talk specifically about precision medicine for rare disease. I will tell you a personal story, why I got involved in precision medicine and why it's become my career. I will tell you about my son Bertrand and how, I guess 6.5 years ago, he became the first case ever discovered of a brand new ultra-rare disorder, and my attempts to build a community and find therapies after that. And then I want to talk about expanding this vision to precision medicine for all rare disease, using Bertrand as sort of a template for providing hope for everyone. So what is precision medicine? So back in 2015, President Obama launched the Precision Medicine Initiative, and behind that there was this sort of hurricane of phrases that came out behind it about what precision medicine means. And so I think there is, in fact, a way to unify all of these differing definitions, from the right drug to the right patient at the right time, to personalized medicine, to genome-guided medicine, data-driven medicine. All these things keep popping up in the context of precision medicine. And I really think that they all come from the same definition, which is if you take the definition to be optimizing health with data, it entails everything I just put up on the previous slide. So I think there's a way to unify all of these definitions. And I'm going to just dive deep right into rare disease right now to show you how I think that's true. So precision medicine for me is a process. It's a process going from a patient and really their data into the best possible treatment for them. So the way this works is you take a patient and you extrude them into a set of data points. Now, the data that's most frequently cited in the context of precision medicine is genomic data. And certainly there's reason to be excited about using genomic data. It's become a clinically accessible entity, and we can actually do some pretty amazing stuff with it now. But to me, precision medicine is even more encompassing than that. I'm by training a computer scientist, and so it's still how I think today. I think data is one of the greatest drugs that we have. And certainly that will be the case when we look back at the end of the century in terms of how well anything did as a broad spectrum therapy. So all forms of data are in scope for me. And that includes your medical records, your Apple Watch data, high content imaging, and anything else you can get your hands on when it comes to treating a patient. Because we can use all that data to turn this into an optimization problem. We can define a model under which we're varying environment and treatment to give us the optimal treatment for any individual patient. So that's how I think about it. And this is why we think of it as, it's the right drug to the right patient at the right time, because it's very individualized. And because much of that data is coming from the patient themselves, it's personalized. And then, of course, in the context of precision medicine, you often hear it associated with stories like the one we just heard, and others like it, where these heroic parents and patients and scientists are charging in and doing science as medicine, because there's no medicine you can take at the time. And so there's stories like this that are out there, and that's why you often hear precision medicine as being patient-driven. And again, the prior talk was just a fantastic example of how that's true as well. And the reason that this is happening is that if you look at this as an optimization problem, again, sometimes there's missing data. We don't know what the best drug is, because maybe we don't even know how to solve for it at that point. So this is where science comes into play to finish building out the model to show us the right ASO to take in some cases, so that we know what to do. So in this process of going from a patient into a pill, sometimes it's not a pill that you take, it's an experiment that you do, it's science that you do. And from my experience at UAB and running the Precision Medicine Institute there, I can tell you roughly what this looks like right now. So using data alone, we seem to, about 8% of the time, be able to find some kind of recommended therapy for an individual patient. And 92% of the time, we're going into the science, and we're coaching them into the science in this process. So what I'll do now is just tell you about, again, how I got involved in this. I'm going to tell you about my son's story. And again, this is the story of what happens when you're told, as we were about 6.5 years ago, that your child is the first case ever discovered of a ultra-rare disease. In the interest of time, I will speed this up a bit. So it turns out we're one of the stories that sometimes get cited in the context of precision medicine, and part of this was told a few years ago in the New Yorker. And in our case, 11 years ago when this all started, we didn't know what was wrong with Bertrand. We had no idea what was causing him seizures, and at that time hundreds per day, why he had a movement disorder, why he had extreme developmental delay, and why for some reason he could not cry tears. Now he could cry, but he would never make liquid tears. So again, in the interest of time, skipping over things, I'm going to just sort of fast forward through the first 5.5 years of Bertrand's life in about 30 seconds. So what happened was, I finished my PhD in computer science, went out to get my first faculty position, and in tandem with landing that, on the very first day on the job, Bertrand goes in at 6 months old for a developmental pediatrician appointment, and he's told that something is very wrong. This kicks off a diagnostic odyssey. We end up realizing after about 2 years that he needs some kind of genomic sequencing to uncover what's wrong with him. That happens through a research study at Duke University. And then we're told, about 2 years after that they have an answer. And it looks like this is what's called NGLI1 deficiency. And then there's this little caveat they throw in that says, and by the way, if this is what it is, he really is probably the first patient anyone has ever seen. This gene has never even been linked to human health in any way, shape, or form thus far. So that's a shock. I think as a parent, everyone wants to believe that their child is unique. But that was a little more unique than I had anticipated, that's for sure. So, more things happened. We kept rolling, and we started doing some science. So within literally weeks, we were teamed up with a glycobiologist out in San Diego, this guy named Hud Freeze, to start working on the fundamental biology of this disorder. At the same time, I wanted to find patients. So to find patients, I wrote this blog post. And this blog post was really designed to do two things. It had to go viral, and it had to rank very highly in Google search results for all the right symptoms that a patient for this disease might type in. And the crazy thing is it actually worked. So today, 6.5 years later, we have almost 70 patients around the world that we know that have this disease. And we're all very much in communication with each other and working together to understand, treat, and cure this disease. So fast forwarding some more, over the next couple of years, we did a lot of science. We actually partnered with the NIH. We got a lot of these families to enroll in a natural history study to really unlock what was happening inside of this disease. And then this is really the point up to which you can get with the New Yorker if you want to know all the details. But the point is, about 2 years after the discovery of the disease, we had enough knowledge of it to really ponder doing drug development. Because that, for me, was the goal. So we kept going with the science, and eventually, about 6 months later after that, with more science, I realized, sitting down, actually having coffee with one of the NIH researchers, that if you sort of worked out the rational basis for what was going on with Bertrand, that he's missing this enzyme, and enzymes turn A's into B's, and it looks like he's missing a certain B in this case. I realized that, there's something that Bertrand likely didn't have in his cells, and that something happens to be N-acetylglucosamine. You wouldn't typically eat this unless you're in the habit of eating the shells of shellfish. But it turns out you can buy this on Amazon. And so I bought this on Amazon. I took a bottle of it myself, literally an entire bottle in one night. And I woke up alive the next day. So that for me was effectively FDA phase 1 clinical testing. And then there was the wrestling with, well, do I give this to Bertrand? Because it's one thing to try this on yourself. It's another thing to try it out on your child. And what happened was he went to the hospital. He used to get these horrible recurrent lung infections. And so he said, well, in the middle of this, he came very close to dying. And I thought, oh, my God, what if this bottle was sitting on my shelf this entire time and I never tried it? What if I never found out if there was something that it could do for him? And I just realized there's no way I could forgive myself as a parent if that happens. And so I said to my wife, I said, once he's better, once he's out of this hospital, we're going to get him out. And once he's stable, we're going to try this. And we're going to see if there's anything that it might do for him. So he gets home, he gets stable. And about 3 days after I put him on this compound, I walk into his room one morning, and I realize that he's crying. And he's not just crying, but he is crying tears. For the first time in his life. And he's cried many more since. But yeah, it's something I'd never seen him do. This is a child who had to have eye surgery to correct some of the horrific eye infections he's contracted as a result of not being able to make almost any eye moisture at all, in fact. At this point, we were debating whether or not to give him a tarsorrhaphy, where they were going to sew his eyelids effectively shut to protect what remaining vision he had. So to see that, it was a shock. It was definitely a shock to see Bertrand actually cry tears. And luckily today, his vision's perfect. Like he's not had any problems since, and it's the same for the other patients that have gone on this compound as well. So fast forwarding some more, I realized, okay, well, it's, I mean, honestly, tears alone were fantastic. But yeah, I wanted to do more for Bertrand. And so I actually managed to partner with some folks at my old institute, the University of Utah, and get a grant to do real drug development for this disease. And so what we did is we started playing with worms. Not just any worms, but planarian worms. And the reason I love planarian worms is that if you want to study a developmental disorder, they have this amazing property. If you take a planarian worm and you cut it in half, what you get is 2 planarian worms. So they're fantastic for studying developmental phenotypes. Now, something really interesting happens if you take a planarian worm and you give it NGLI1 deficiency. Does anybody know what happens if you take a planarian worm, give it NGLI1 deficiency, and you cut it in half? Do you know what you get? What you get is a worm that's been cut in half. So it loses this capacity to regenerate, which is exactly what we'd hoped would happen, because that meant we could look for ways to get this to come back. And there was some evidence emerging around the time that there were some potential modifiers for this disease. And one of them, in fact, was a gene called NGase. So we did a double knockdown experiment. We knocked down NGLI1 and NGase at the same time. We cut this worm in half, and suddenly it regenerated. So that was interesting. It looked like we'd found a way to potentially tackle this disease. So the next step after that was to find an inhibitor for NGase. And at this point, I could feel my life getting pulled more and more to computer science, into biology and medicine. And this was a chance for it to finally take a step back into the computer science. Because if you want to find an inhibitor, there are principled ways to do this. So what we did is we actually found the crystal structure for this target enzyme, NGase. Now, at the time, there wasn't a human crystal structure available, but there was one for some bacteria. And so we did homology modeling. We transformed it into the crystal structure that we thought was loosely going to resemble the human form, and particularly around the catalytic domain. And then we did docking simulations on this thing. And we looked for small molecules out of a set of 200,000 that were inverse in shape and charge to the catalytic domain on this protein, something that could potentially act as an inhibitor of this enzyme. And through this process, we actually found that there were 70 compounds that looked like they fit. And amazingly enough, 14 of them were already FDA approved. So we took these 14 to the lab, we used mass spec, and we checked to see if any of them were true NGase inhibitors, and one actually was. So one actually worked in the lab when we tried it out. And that one just happens to be Prevacid. So you can get Prevacid at Costco, which is what we did. And and so Bertrand went on, and what we expected, this is about 2 years ago, 2.5 years ago even, what we expected to see was perhaps a slow gain in development over time. And certainly what we've seen is, in that period is remarkable. So he's actually, at this point, he's a pretty happy kid. So he's seizure-free. This is a kid who had hundreds of seizures per day when he was born, and he's now down to 0. I mean, I haven't seen him have a seizure in the longest time at this point. And his vision, as you can see, is perfect. He doesn't have the cloudy, hazy corneas he was getting from this constant erosion. He makes tears just fine. He still has some developmental delay for sure. And he was stuck for 9 months. It took essentially 9 months of development for a very long time. And that takes a toll. But he has actually started making forward progress in these past couple of years to the point where he's qualified to use an eye-gaze computer. And this has been pretty transformative for him because it's unlocked a way for him to communicate with the outside world, which I just didn't honestly think was previously possible. And so he's very consistently now expressing preferences for certain things like, leave me alone. And I only want to eat yogurt and things like that. But also, even more recently, he has expressed a very clear preference for fish. He wants a pet fish. And not just any fish, he wants a whale shark. And he's very, very clear that it's a whale shark specifically that he wants. So we're going to get him an aquarium, probably not a whale shark. But yeah, he'll get it. And this put me on a trajectory. So as this was happening, I ended up getting an invitation to join the faculty at the Harvard Med School. So I remember it was a kind of surreal moment because I thought, I'm a computer scientist, and my furthest qualification in biology, I think, is a C in the 6th grade. But if you think I could be a professor here, why not? Let's do it. And then, not long after that, I ended up meeting this guy. So I got an invitation to go to the White House. And he said, what I'd like to do is launch this precision medicine initiative so that we can do the kinds of things that you've done for your son, for everybody. That's what we want to do. So again, I thought, well, I think there's never been anybody less qualified for something like this, but what the heck, I'll do it. Why not? So that started for me a 3-year odyssey working at the White House. So I did help launch the Precision Medicine Initiative. I think the first thing I did was actually help co-author one of these white papers that launched the entire thing and laid the foundation. It's now become ultimately the All of Us program. This is this cohort program that is seeking to recruit 1 million Americans to donate their health records, their DNA, to create what I would call the Rosetta Stone of the human genome. And this led to even more spectacular opportunities for me because there was an election, some things happened, and I looked for new employment and ended up going to UAB because they offered me the ability to create a precision medicine institute from scratch and to really lay down a vision for how we were going to achieve precision medicine for everybody. And so I won't talk about all the things we do at the institute, but I will tell you that this is not, we do a lot of rare disease. It's obviously near and dear to my heart, but the goal here is to bring this kind of care to every disease, whether it's rare, common, or chronic. So again, if you look at precision medicine as a process, there's really 2 big chunks of it. And the first chunk is precision diagnosis. You've got to figure out the root molecular cause of the disease. The second chunk of that is precision therapy. And I do think of these as 2 major distinct phases. So we're very focused on both parts of it at UAB. In terms of precision diagnostics, I think we have a really excellent example of how to do this in the form of the Undiagnosed Diseases Network. So UAB is actually now a co-coordinating center with Harvard for the UDN. And if you know folks that are on a diagnostic odyssey, like Bertrand or like Mila, and need help, this is a great place to send them. That they're turning this from an art into a science in terms of how you find the root cause of these genetic disorders. And then comes the hard part, which is how do you turn that information of this root molecular cause into a therapy? So there's a lot of stuff you can do for this, and I'll describe some of it now, including to me what has become sort of the most exciting part of the work that I'm doing. So I think if you really want to scale this up so that we can do this again and again and again, we're going to have to use artificial intelligence. And I'll talk to you about a piece of software that we're building at UAB and then some cases of where we use it and what it's been able to do. So it's called Medicandor, and in fact, actually, the Broad is one of the other participating teams on this project. And so the Broad has been highly collaborative with us in this effort. So it's been great to work with the folks here. And what it's really trying to do is combine logical reasoning with biomedical knowledge. In fact, all the biomedical knowledge that we can get our hands on. So if I were to give you the ultra-condensed version of what this is, it is old school logic fused with high-speed automated reasoning to achieve superhuman-like deduction with clinical insight. That's what we want to do. So we built a tool, and you can ask it questions now. You can ask it very targeted questions, like you can say, find me an inhibitor for X, or tell me what might treat some disease X. And so you can really, you can ask it very high level, you can ask it very low level, and it will give you back answers. So for example, I ran this query the other day on behalf of a patient that was having a very strange case of overactive bladder, and it found that there were at least 145 inferable treatments for this disorder somewhere out there in the literature. Whether these are direct treatments or indirect treatments, there's 145 that are out there, many of which their physician did not know about. And then, you can ask it very hyper-targeted questions too, and for less common conditions. And so one we did this for was Fanconi's anemia. It came up with xylitol. And the chain of reasoning that it had pieced together to do this, so because like xylitol, by the way, it's like the sugar alcohol that you find in chewing gum. It said xylitol may be a treatment for Fanconi's anemia because xylitol inhibits alcohol dehydrogenase. Alcohol dehydrogenase produces reactive aldehydes. Reactive aldehydes cause double-stranded breaks in DNA, and Fanconi's anemia patients can't repair those. So that was the chain of reasoning it had to go through to find this. And it found like 10 other things as well. But this is compelling enough that the Fanconi's anemia community is grappling onto this and saying, well, hey, why don't we do a clinical trial to see if this can prevent some of the head and neck cancer that we see so frequently in these patients. And so, and it seems plausible enough to the experts in the community that this could be a real treatment. So that's how it thinks, and then that's how it can find potentially new treatments for old disorders and new disorders. So there's definitely a secret ingredient in pulling all this off. So to actually do this, we really did have to read essentially every paper that's ever been written, all like 28 million of them. And of course, we didn't do that. We didn't actually go through and read every paper in PubMed, or really just the abstracts, which is what we can get our hands on. We use natural language processing. So we had machines actually do all the reading for us and condense all that down into a knowledge graph that we could query. So that's what it's done. And that's why anytime a result comes out, you always double check it because sometimes they make mistakes. But that's why what we have to interface with this tool, even though it's open source and anybody can download it and use it, is a research consultation service. Because I fundamentally believe that if you want to scale this up, you have to have a service that will take a patient that might not have a grasp of biology and plug them into a step-by-step process, a process that takes them closer and closer to, through the science, a treatment or a cure. So I'll show you the process in very high speed right now that goes from a patient into a pill. And in the case of rare diseases, it's going to begin with something like sequencing and then go through a number of other phases after that. So again, this is just the high-speed version, not meant to be, it's not going to be on the test, so don't worry about taking notes. And what it's really branching on is, what's the impact of this gene mutation? Is it a total loss of function? Is it a gain of function? Is it a haploinsufficiency? Is it a dominant negative? And based on the direction you move, it's going to have a set of things it's going to prescribe for you to do in terms of experiments that come after that, and ultimately land you in what will hopefully be an N-of-1 clinical trial. Well, so far, we've actually scaled this process to the point where we are meaningfully engaging with on the order of hundreds of patients since May when we opened this program. So I have to give a lot of credit to my team at UAB for doing this, about half of which are actually undergrads, undergrads that we've trained to dive into the literature on behalf of patients and use the software that we've built to come up with research proposals that we then send back to treating physicians. So I'll close with just a few stories of some of the things that we've been able to do through the Institute at UAB. And the first story is that of a 5-year-old girl. So she ended up going into the emergency department at Children's Hospital down in Birmingham. And she had recurrent lung infections. In fact, she had multiple simultaneous infections going on at the same time when she came in, and she was unresponsive to antibiotics. So there's such a concern that both the physician and the parents reached out to the Institute at the same time and said, please help us find something that we can do. We found from when she was about a year old a genetics report. And in that genetics report, there was a chromosomal duplication that at the time had been sort of overlooked. Turns out the range here was in 1p34.1, and there were about 12 genes involved in this duplication. One of them was PRDX1, and it turns out that even though this hadn't been associated with human disease before, if you overexpress this gene in rats, you get something that looks very much like this disease in rats. So that was compelling, but not enough to say, well, this is it. So I turned to Lisa Basteresh at Vanderbilt, who has special access to the EHR there and was able to query it for any patient that had a matching duplication in this range. And she found 2. One of them overlapped PRDX1, and sure enough, that patient had the exact same phenotype and ended up dying while intubated. So it looked like this was indeed a very serious condition. And then we found another patient that had a very narrow duplication in this range, but that did not overlap this gene, and they did not have this airway disease. So we thought, okay, this is compelling. This is probably what this is at this point. So now we need to understand, what is PRDX1 doing? And it turns out it has 2 roles. Inside the cell, it's an antioxidant. And it looked like what was happening is perhaps it was too effective in the sense that it was leaching the supply of hydrogen peroxide necessary to lyse invading bacteria. And then once it goes outside the cell, it's a TLR4 antagonist, or agonist, which meant that it was actually having this pro-inflammatory effect as well. So sort of a double whammy in terms of her condition. So we needed a PRDX1 inhibitor, and we needed a TLR4 blocker. And again, using Medicanum, we were able to find both these right away. So for the inhibitor, we found a few things, including a traditional Chinese medicine called Diaskin. It's a phytosteroid that looked like it would actually serve as an inhibitor. And for the blocker, we found naltrexone, the opioid abuse drug. And we turned this over to the physician, and she said, no, there's no way I'm putting a 5-year-old on either of those. I need something else. I need something that I'm comfortable actually prescribing. So we went back, we dove back, and we said, let's try something different. We looked at the regulators of PRDX1, and one such regulator is NFE2L2. We said, can we bring that down, and then hence bring PRDX1 down with it? It turns out you can, and so we found ascorbic acid and luteolin to do that. In fact, we even found a study where this was used to treat patients that had an overexpression of NFE2L2 and hence PRDX1 that had a very suspiciously similar airway disease. So she also went on an airway clearance protocol, and this all started happening in November, and so she went from 29% small airway function at the time to several months later, 70% airway function, and she's been out of the hospital this entire time. So it's not solved by any means, but it's a significant step forward in her treatment at this point. So we're certainly optimistic there. And I'll close with one other case, say that it doesn't always have to be genetic in nature to do this. And the final case is actually of cyclic vomiting syndrome, which has got to be day to day one of the most horrific diseases I think I've seen, because you just never stop throwing up. And this was a 19-year-old woman who was having multiple episodes per day. She was down to 78 pounds. She had had this her entire life, ever since she was young. And using our methods, we were able to identify inhaled isopropyl alcohol as a potential treatment, turn this over to her physicians, and sure enough, it has actually worked. So she's been 5 months without vomiting one time, and is now up to 106 pounds. So we never found the genetic basis for this, but we did find plausible molecular bases, which allowed us to make that inference. And so, the point here is that, precision medicine as a process is rapidly evolving. It's becoming systematized. We've encoded that now at UAB in this research consultation service where patients or foundations or physicians, they can reach out and say, I don't know how to handle this case. What can we do with all the available data that we have that's out there in literature, that's available on this patient? What can we do? So with that, I thank you for your attention.
Okay, we'll have all of you now come up. We have a little bit of time left for some Q&A. Why don't we have all of our participants come up? Oh, it's been an amazing afternoon. We heard some incredible stories. First, I wanted to see if there's a burning question in the audience from everything we heard today. And if not, I'm going to start. I'm sorry, I'm supposed to not step too far forward, but you can't see me very well, so I'll try to do my best to. So thank you all for coming. This was an amazing afternoon, and every single one of you has told us from your own perspective a very, very compelling story that really drives the point home why we're here today commemorating Rare Disease Day and why all of this matters a great deal. We're in the Broad Institute. The founder of the Broad, Eric Lander, was part of a team of scientists many years ago who started something called the Human Genome Project. It's interesting to say that it took a little less than a couple of decades to sequence the first human genome, to really get through one human genome. And now here at the Broad and many other places, here at the Broad we sequence a human genome every 10 minutes. The scale with which we have made progress is tremendous. And yet, here we are now looking for ways to sort of take the next step beyond the diagnosis of being able to find treatments for patients with both rare and common diseases. So I want to ask you, each of you, if you can just think about where do you think we are going to be in 5, or you can also be bold and say, 2 or 3 years from now, from your perspective, from each of your perspectives, where do you hope that we can be in using our technology, our compassion, our ability to understand patients, our ability to communicate with one another and organize ourselves across the world in the world of rare diseases? Where do you hope that we can be? Maybe anyone can start, but Nat.
Sure. So I'll break it into 2 chunks. Let's talk about the diagnostic half, and let's talk about the therapeutic half. So right now, if you look at the diagnostic half, if you are suspected to have a genetic disorder and we sequence you, you have about a 1/3 chance of getting an answer, which honestly is not high enough. It tells us we're still not good enough at interpreting the human genome. But obviously, this is a problem that collectively through, as a scientific community, we will solve that. We will be able to do that. So I suspect that diagnostic rate will eventually climb all the way to 100 or very near that. On the therapeutic side, I think we've seen the future today. And I think the future is antisense oligonucleotides. I mean, ASOs they're a total game changer for me when it comes to precision medicine. A lot of what we would have to do through drug screens before we can now do through rational drug design, to specifically target individual genes with low side effects. I mean, it is a phenomenal technology, and I do think it is the game changer over the next 5 to 10 years for sure.
Mm-hmm. Yeah. Julia, what do you see?
My hope, of course, is that there'll be more treatments like Mila's, along those same lines of what Matt was speaking about. I mean, I envision customized genetic clinics, within medical centers across the world where kids like Mila and Bertram walk in And maybe in the beginning, out of 10 kids, maybe one of them can be taken from diagnosis to treatment. And then over time, maybe that turns into 2 and 3, and then eventually 5 and 6. And then over time, probably definitely not in 5 years' time, but over time, hopefully, 10 out of 10 of those kids will be able to be, taken from diagnosis to a customized treatment that could be just for them, like in Mila's case, or it could be for a larger population. That's kind of where my hope is.
Yeah, sounds wonderful.
I obviously share a lot of the same hopes that both Matt and Julia have enunciated. I think one of the things that you mentioned, Anna, was how the process for developing the very first map for the human genome was a process that took decades and $3 billion, and now it's less than $3,000, right? And I think that same revolution has got to occur on the therapeutic side. Mm-hmm. The beautiful thing is that the investments that we've made over decades in several different classes of pharmaceuticals, ASOs are the one that worked for Milason, and there are others that deserve that same level of attention. AAV gene therapies, slightly more complicated, but also can be a platform upon which therapies can be rapidly turned around. There are other esoteric types of chemistries of the same class as ASOs, morpholinos and so forth and so on. The key thing to all of these is that they're essentially programmable medicines. They take advantage of reusable components that can be just customized in a way that's much more logical than trying to make a small molecule dock into a protein. Mm-hmm. As elegant as that still can be, and there's still promise in that area too. Mm-hmm. So those are the areas I think that we ought to really focus on the next several years.
I believe that from beyond the diagnosis point of view, the goal is to make all of these big, scary, intimidating names and words human, and to make them more approachable to everyday people, not only researchers and pharma people, to have more of a heartfelt pursuit of finding cures, finding answers. If it's not affecting you, as I know how hard it is as families, you fight hard and you're a greater advocate. So it's the greater reach, understanding through art something that we can all hopefully experience, and to raise that awareness, to bring in, cast a wider net so people can learn more.
Can I follow up that by asking, you have specifically, Beyond the Diagnosis, has made some outreach efforts beyond the United States, and that's really something to think about as well.
Yeah.
Of course, we have a precision medicine initiative here. We have tremendous scientific know-how in this country. There are other parts of the world that may not benefit as much from this kind of connectivity. I know you've even had portraits from Africa, which is really wonderful. We had one unveiled, I think, 2 years ago here at the Broad, which was wonderful. So can you speak to that a little bit? What does that feel like, connecting with patients in remoter parts of the world?
It's been amazing. And we're finding artists and patients that match up in South Africa, and it's helping people that would never have the opportunity to even know that they would have hope, and just bringing in a whole different group of thinkers and patrons and people that can really help the cause on this global level, and all a bigger support system.
Yeah, it's clear that Beyond the Diagnosis is well on its way to do that. Any questions from our audience? Yes. We have
So, that's loud. So I'm a genetic counselor. I'm a bit unique that I've always been based in the lab, but a lot of my colleagues obviously are the ones who returns the results to patients and are there on the front lines as it's happening. And I find us at this really fascinating point where we're, for a long time as genetic counselors, our jobs were to sort of give the results as the state of the state. This is currently what we know about this disease, whether it's novel or well known, and to be compassionate and understanding, but to not necessarily overinflate any chances of where things could go. And I find that Things are obviously changing quickly, and we have some early research showing that a lot of genetic counselors are very hesitant to talk about any gene therapy or any sort of treatment opportunities because they don't want to give false hope, but they also don't want to remove hope either. And so I'd just be interested to hear from you, both as researchers and as parents, what are some key phrases or some key resources that genetic counselors could give to families in that time to sort of say, things are changing, but it's not known at this exact moment who's that 1 in 10 at the very beginning, or where is the place you can go to increase your odds, but still allow families to feel empowered and to maybe have those glimmers of hope, or be proactive and start to reach out and take it on themselves.
I will happily start. Sorry, my mic is not working, so. Is this, hello? Hold on, okay. I don't think it's
working. Is that working now?
No, okay.
No.
Just talk loudly. In Colorado, where Mila was diagnosed, the genetic counselors there on a regular basis give my email and telephone number to pretty much everyone, and I have told them that I'm more than happy. It's obviously a lot of work on my part, but I get calls and emails all the time from families that are recently diagnosed or just diagnosed even the day before. I'm sure Matt probably gets a whole waterful of them as well. And I'm glad that they do that because unfortunately, I think to answer your question, there really isn't a central place to go. I will mention a few names, including Matt. I'll mention a few people that they could go to, but there really is not a hub. There's a number of different organizations. I try to offer them what I can, which is hope, and I offer them whatever I felt was helpful for me. So I direct them in the direction of articles, of companies, and just honestly of just get going. Start a foundation if you feel like you want to. Start going to certain conferences and start asking questions. I think asking questions and not stopping until you feel like you have your questions answered. It's not an easy one direction, but it certainly empowers them. And they often get off the phone saying thank you because I felt completely lost and I was told that I had no hope and there was nothing I could do. So I think just giving them the kind of the confidence and a little bit of direction helps get them going.
Yeah, I'll just say that, again, people email me all the time too. And one of the reasons I took the position at UAB was that it would enable me to create the infrastructure to answer my email. And so, I can now very quickly, when I get one of those emails, tag the program coordinator and say, okay, let's put this person in the system. Let's do a case review, because we have Monday case reviews. We look at all new cases coming in. We do an analysis. We try to give them immediate feedback on what we think those next steps are. And then we stay engaged. So we are creating that infrastructure for helping to coach patients through this long process all the way from diagnostics to therapeutics.
It's really a remarkable effort, and I think it will scale, as you say. So I think it's been a wonderful and long afternoon, but I think it's time. Oh, you have a question? Yeah. Burning question. Okay, we won't let you. Right there. Thank you. One more question.
So I'm involved in personalized medicine, chief scientific officer of an ultra-rare disease foundation. And one of the things that I've been thinking about in thinking about other diseases is, and this is really addressed mainly to Matt, is it possible to develop an algorithm with all of the current information about the known genetic diseases where it wouldn't be random which of the 10 kids that walk in are treatable? Because from where I sit, it seems that one could priority rank order the likelihood of being able to treat different genetic defects, and that might be an incredibly useful tool for the community.
Yeah, so in fact, I mean, the way I phrase it is all conditions are treatable ultimately. The question is, what's it going to take to do it? So when we analyze a case, what we rank are the potential ways that you could actually go about treating it, whether it's an ASO or it's a repurposing screen, a gene therapy, and we try to present those as options back to the family and say, well, these are our best guesses as to what might be the most reasonable options for you. And in some cases, actually for a reasonably large fraction of cases, it's a single gene, and it just needs to be pushed up or down. So we're just looking for an activator or an inhibitor, and oftentimes you can find this stuff out there in the literature. And that could become the basis potentially for an N of 1 clinical trial with some engaged physician scientist.
Looks like we have one more question. Okay, wow. People are warming up.
Thank you for this, and I'll make it brief. My question is, can you help us understand the economics behind individualized therapy? I'm from Shepherd Therapeutics. We are a rare cancer firm. We are 13 people. And from the science side of it, I'm a researcher, but I've been told to learn money is more important. How do you counter the cynicism of investors?
Tim, you want to?
I'll take a shot at that.
That's a tough one, yeah.
I think there are scientific advances that are really pushing the envelope of the financial models that we've set up to support medicine. And let's just leave it at that. It's a real problem. However, in the next couple of years, we have the chance to carefully explore these options and perhaps consider changing the models. One model that's squarely in the pharma space is the idea of reimbursement for medicines being predicated on the success of that medicine. Right? You don't pay if it doesn't work. That has some advantages to the system that allows exploration of new investigational agents, new investigational platforms. Right now, for instance, speaking about Mila's investigational drug, there's a question as to whether or not insurance will ever pay for a drug like this. Well, that's a conversation really worth having. And if it actually does impact quality of life, why not? I think there's lots to be done in this space. I think of many drugs as being priced by industry via models that are distinct from treatments that we give in the hospital. Surgeries, appendectomies, organ transplants, bone marrow transplants. And there are different models with different advantages for each of those different types of treatments. And many times the most personalized treatments actually come out of hospitals. A bone marrow transplant matching you to an HLA-matched donor is a very hyper-personalized treatment. And it's not, strictly speaking, a commercial pharmaceutical endeavor. It's hospital-based. So I think these are some of the issues that we'll wrestle with and try and come up with a better answer to that in a couple of years. But right now, I just acknowledge the issue and say that we are thinking hard about it.
Do you have a comment, Ben?
Yeah, and I'll say that, as with anything, there are economies of scale here. So as this scales up, the cost per patient do start to drop with time. Yeah, innovation is happening at a sort of a breakneck pace, in fact. And so I'm optimistic long-term that the price point will become reasonable. But already at this point, I think the value is clear. And if we do move towards a value-based model of reimbursement, I think it becomes accessible much sooner. And I think what's happening right now is sort of the groundbreaking pilot experiments that will demonstrate that value and give insurers a rational basis to reimburse.
Very good. If there are no other burning questions, I think it is late in the afternoon, so I wanted to very much thank Suzanne, Tim, Julia, and Matt for joining us this afternoon. It's been a wonderful journey through personal stories and amazing scientific feats. And I think the future is bright. Thank you all for coming, and please enjoy your reception we have afterwards outside. Thank you.